Now we will present the feminine power of this block. Dr. Matamala, she is a specialist in internal medicine and a specialist in clinical endocrinology and diabetologist. She is also works in Ing2 Hospital in Chillán and member of Xochitl. You were recognized. Thank you, Claudia.
Bueno, entonces vamos a seguir efectivamente las charlas con usando correctamente la data
Now, I will present using correctly data for monitoring. First, I will speak about continuous glucose monitoring. Hans spoke a lot about this, and it will be short, and then I will focus on the essential features of the time and range, glycemic variability, and indicators of glucose control besides HbA1c. And when we will talk mainly about the curve of the outpatient profile and some concepts such as midline, interquartile range, and interdecile range, and the systematic interpretation of the profile. These are my disclosures. And continuous glucose monitoring is the most advanced method to monitor the glucose levels, offering information about critical areas to improve glycemic control. As shown by Hans, you know that HbA1c is a robust and validated biomarker to predict risk in the long range, but it also has significant limitations, and this metric is not able to reflect the glycemic dynamic, the daily fluctuations, and the frequency and severity of the hypoglycemic event. And this is a classical curve where we may have very different glycemic profiles compared to HbA1c. So it continues glucose monitoring gives us a lot of information, and this information is condensed in this outpatient profile for glucose. This is a standardized protocol that summarizes graphically the data that have been obtained and allows to identify the greatest risk of glucose variability and hypoglycemia. The time and range consensus established 10 metrics that have to appear in any outpatient profile of glucose. And so for practical effects, I will focus mainly on the freestyle profile. What are the challenges? It's being able to use all the data given by continuous glucose monitoring and interpret them adequately to be able to reach a good treatment for our patients. Within the essential features of continuous glucose monitoring in an outpatient manner, first it says the number of days of the sensor, and the minimal use of sensor has to be at least 7 days to be able to be interpreted, and the percentage of active sensors has to be at least 70% so we can interpret data. The use of monitoring for 14 days is correlated even better with an average glucose in the last 3 months, time and range, and interglycemic metrics. If we focus on time and range, Hans spoke about this, we know that time and range gives a clinically relevant assessment of daily glycemic control. Time and range is 70% that has been established, equivalent to 16 hours and the target, and retrospective analysis of capillary self-monitoring evidence that for each drop in 10% of time and range, there's a 64% increase of risk of diabetic retinopathy and an increase of 40% of risk of diabetic nephropathy. What are the objectives for the patients? You know about this, but for type 1 and 2 diabetes, over than 70% of time and range. However, for elderly patients, fragile patients, or greater risk of hypoglycemia, the main objective is to limit time in hypoglycemia to less than 1%, with more loose targets equivalent to like HbA1c of 7.5%. In pregnancy and diabetes type 1 or gestational diabetes, we will have a more strict targets. Is it enough to consider only time and range to say that our patient is well controlled? Of course not. Here we have 3 cases of patients with a similar time and range. However, the most important feature is the presence of hypoglycemia in them, which is different from among the patients. And we have the concept of glycemic variability. Glycemic variability has to do with this measure of oscillations in the level of glycemia that cover amplitude and frequency of these fluctuations. There are numerous factors associated to glycemic variability, and it depends on the function of residual beta cells, secretion of glucagon, lipodystrophy, exercise diet, etc. But what we know is that with a greater glycemic variability, we will have greater risk of micro and macrovascular complications. Therefore, we have numerous metrics to assess glycemic variability, among them standard deviation, coefficient of variation, etc. And the one we use for the outpatient profile is coefficient of variation. Coefficient of variation is calculated as the standard deviation divided by the average of glucose times 100, and we know that a value less than 36% is considered indicative of relatively stable glycemia. This shows in general an inverse correlation with time in range. At the lowest time in range, the greater the glycemic variability, and a positive correlation with HbA1c. The glycemic variability indicates mainly that there is a greater risk of hypoglycemia in our patients. And we have this concept of glucose indicator monitoring that replaces the estimated HbA1c used before 2018. And this formula is a linear regression formula used considering variability, and this is the equation if you want to know about this GMI origin. Is GMI compatible with HbA1c? What is GMI useful for? It's useful mainly to know about glycemic control in the short range. We have to consider that GMI is calculated only with 14 days of data of glucose. Therefore, it could be useful when the glycation process is affected by non-glycemic factors, for example, neutropenia, anemia, or renal disease, among others. It's very important to understand that they are not directly proportional or comparable in many occasions. And why not? Because there are some problems with GMI. This linear regression equation was obtained from a study of 500 patients, 4 studies with 500 patients in total, users of Dexcom. And this formula was obtained from the Dexcom sensor, and there are significant differences between GMI and HbA1c of up to 26 and 68% of patients, and the estimated differences are over 0.5% of percentual points. So what is suggested if we will use GMI, it has to be related to HbA1c. And among the benefits we may find is for those patients denominated fast glycators, where GMI could give us some lights about what is happening with the patient. Finally, we have the lower curve. This is only the first page, and this is the curve of the outpatient profile of glucose, and this curve is a modal day. We obtain all the information for monitoring, and a graph is obtained representing all of the readings of glucose, and we can see them depending on the time. And this curve, I think, is fundamental to be able to do an adequate reading of the monitor. And if we consider this curve, you can see with letter B, the midline, this is a continuous line representing the glucose value over and under which we have 50% of the readings at each moment of the day. And this curve is then the average of glucose of the patient, for example, in 14 days. Therefore, with this midline, we may see the central trend of glucose. Then we have the interquartile range. This represents here with letter C is this dark shade limited by percentiles 25 and 75, containing 50% of the readings of glucose at each time point. And this gives a visual indication of how the patient is doing day to day and the consistency. This pattern or interquartile range identifies mainly consistency in the patterns throughout the day. In this clear line, this shaded area with letter G represents percentiles 5 and 95. So this is the most separate values of glucose, containing 90% of the glucose readings, showing these more extreme situations, but still relatively frequent. So what do I recommend? For the systematic interpretation of the profile, first we must assess the patient, and we have to see if the use of the sensor is in over 70% of cases and for more than 7 days. If that is so, the sensor can be assessed. If not, you have to search for the cases and see the compliance of the patient, but are not do not base your assessment in the profile because it can lead to errors. If the patient complies with these two premises, we can assess the most important thing. First, the presence of hypoglycemia, time under range of over 4%, which has to be investigated. If this is not so, we go to time in range. If this is over 25%, that is our second point to assess. And if this is not complied with, we go to glycemic variability represented by the coefficient of variation. If it is over 36%, here is where we have to assess. If everything's perfect, let's congratulate, let's reinforce habits. Everything is going okay. Therefore, we must assess now this first patient. This first monitoring, if you take a look, we have the use of the sensor for 14 days and the use of the sensor over 99%. So the curve is accessible. And what it clearly calls our attention is severe hypoglycemias. Therefore, it is here where we have to put our focus. Look at the curve, the clear trend of the midline to decrease, especially in this segment between 3 and 6 in the morning. And if you see the interquartile range is also here around 70, which is where it's most marked. Another case to show the same idea, this is a pattern of hypoglycemia in the early morning. And if you see in the interquartile range, there is a drop under the 70 line, and it means that the presence of hypoglycemia is persistent at that time of the day. And this is useful. You see that these glycemias are repeated throughout the days. And if we see the daily graphs, in fact, we have a patient that tends to hypoglycemia in the early morning. What are the causes of this? In general, excessive baseline dose is most probable, but also not in this case, but in others, you can analyze that these may be too high prandial doses after, for example, dinner. And in lesser occasions, it has a high intake of carbohydrates or exercise, and we have an adjusted dose. This other pattern, the same idea, this is another patient, 14 days of monitoring, 100% of use of sensor. And once again, we have hypoglycemias, but look at this pattern. This pattern of hypoglycemia is much more postprandially. The drop tends to be more postprandial, and it stays within the line of 70s. And if you take a look, this means that because the interquartile range drops, it seems that hypoglycemias are very persistent. We look at the daily graphs. If you look at every time of the day that the patient corrects, he or she has a very acute drop in the levels of glucose. And this pattern repeats itself throughout the days with very severe hypoglycemias and very intense hypoglycemias. What may be the possible causes of this pattern of hypoglycemia? Let's see them in general. The causes of postprandial hypoglycemia that are early may be because of too early bolus or bolus that is done after starting to eat. Also double boluses of insulin, but most probably in this patient is an excessive sensitivity and ratio. It is here where we have to work. About late hypoglycemias, the main cause is insulinization, several boluses in a short time period, and the same variability of the patient. Let's see this other case. If you take a look, once again, 14 days, use of sensor adequate, we can interpret these data. And here, the problem is not hypoglycemia, but the time over range that goes over 25%. If we take a look, let's see the pattern. We have two very different patterns here. Hyperglycemia mainly after eating, postprandial in the post-dinner period, and here hyperglycemia, especially in the period between 3 and 6 in the morning, early morning. Therefore, the causes of hyperglycemia are very different in these two patients. In the lower graph, the dose of baseline insulin probably is insufficient, while in the patient at the top, the dose of insulin during dinner is insufficient. Other causes of hyperglycemia that are resistant, antennary problems in general, forgetting a baseline of postprandial insulin, lipodystrophy or poor absorption, or high fat and protein content dinner, and also the use of steroids. These cases now, I come from the south of Chile. My patients in general have a lot of fat intake. And if you see here, this is a case of a patient that
chicharrones.
eats lots of fat in the late afternoon. And look at what happens. It seems that the curve doesn't have a rise, but look at 2 or 3 in the morning, and it's around 400. And this is more usual than what I would like, obviously. But let's see the effect, for example, in this patient, lots of cheese and bread. Look what happens in a patient with type 1 diabetes. At the beginning, there's not a great curve, but after an hour and a half, we have an important increase in glucose or in glycemia. What message can we give the patient? Go between the clouds, between 70 and 180. This is white. There's lots of margin to improve. Don't fear hypoglycemias, because the real fear of showing this curve, we may say there's lots of things we can do. And the other step is, after looking at hypo and hyperglycemia, we see at the glycemic variability. And this glycemic variability is represented mainly by these curves that you can look. It's like a roller coaster. We have interdecile ranges that are very large, interquartile ranges that are very high and variable. This patient has a glycemic variability over 40%. What is the ideal curve? This one, because we have an interquartile range that is very thin, and an interdecile range that is also thin. These types of patients, there is no need for adjustment. What happens here? Look at this case. I don't know if you had found this. This is a little harder to find. This patient has an interdecile range that is thicker and an interquartile range that is thin. So day by day, the patient doesn't have much variability of glucose, but he has occasional variability. In what cases can we find this? When patient has unplanned exercise, some days exercise, others not, forgetting boluses, irregular eating time, unplanned eating, or intake of alcohol. What happens if we find an interquartile band that is very thick and an interdecile thin? Interquartile range is the one that more precision or more applies to treatment. If we find lots of variability of glucose in this time of day, it's probably related to treatment, insufficient ratio or timing, in this case before dinner. What if we find an interquartile range that is thick and interdecile thick, high variability of glucose during the day, occasional variability of glucose, so we require treatment adjustments and lifestyle adjustments? And what are the possible changes or causes? And what we have talked about: shifts, unpredictable schedule, snacks some days, others not. This is like life itself, different activities, social activities having to do with alcohol, forgetting doses of insulin. Therefore, here, what is most important is not increasing or decreasing doses or changing ratios or sensitivity, but changing behavioral things. And after that, we have to see therapy. What is our message for the patient? Roller coaster. It seems you're in a roller coaster, and the patient can look at this as it's good to not to go in the roller coaster anymore. And reinforcing this concept of glucose variability is something we don't want. And let's go into the details. Once we saw the curve, we obtained conclusions from the more classical patterns that are seen. We can see the day-to-day. And here we state the question: is the problem caused by a glycemic pattern observed in many days, or just one? Is there a difference between weekends and weekdays? And this occurs frequently. This is one of my patients using a pump, and if you see, these are 3 days, 1, 2, 3, 4. These are very different days, so this patient has a high glycemic variability, and I want to show why. Look at this day, for example, here, patient did not have a bolus, and because there was no bolus, there was self-correction, but in fact, he had a hyperglycemia curve that was more maintained. Look at this case, the patient had a bolus, but probably did not count the carbs, did not count them well, and also is higher. Look at this case. This patient the next day eats fat, and because he eats fat, there's lots of self-correction of insulin, and it is higher, the glycemia, many hours later. And look at this, patient has a bolus, another bolus, and because he sees it's still high, another bolus with fake carbs, taking this patient to a severe hypoglycemia. So if you take a look here, the problem probably it doesn't have to do with therapy, but with re-educating the patients, especially trying to not omit boluses and a better management of fatty intake. As a conclusion, the growing use of continuous glucose monitoring in diabetes type 1 has enriched the glycemic control assessment with a series of dynamic parameters that complement the values of HbA1c. The correct interpretation of data allows to individualize interventions and therapeutic objectives, and the use of monitoring and adequate interpretations helps guarantee greater satisfaction with treatment, better quality of life, and improvement in metabolic control. And what can I say? Please get the most from the outpatient profile of glucose. Thank you.
Muchas gracias, Pamela, por la excelente y práctica
Thank you,
conferencia.
Pamela, for that excellent and practical conference. We invite you to come to the panel.